right? Healthcare is in crisis right now. Our facilities are strained, hospitals are strained, nursing homes are strained, assisted livings are strained. I just saw an article this morning that Arizona is looking at sending COVID patients to assisted living facilities. I'm just thinking New York 2.0. But that's where we're at. Staffing is a big problem. You all may have seen the article or the news item in Lake Worth, a nursing home there that shut down. And it's because they got COVID in the building and staff said, we're not coming. And you got to shut down a building. Financial burdens, right? Your census has dropped in many places. You have less access to patients, even with waivers, even with telemed, all these things. We're just trying to struggle as to what to do, right? And that's, of course, as we talked about, loss of census and volume. Hospital census is down. Back in March and April in Texas, hospitals were having to advertise saying, please come to the hospital. It's safe. Now they're cutting back again on elective surgeries because they're starting to see that maybe not so much. So in that time, it's really taken a hit because we get paid on a per person, per procedure, per charge basis. Let's talk about number 5, restrictions on patients and families. Patients have not seen their loved ones in person for 4 months. They're not going to see them for the next 6. You talk about the reopening in certain states. CMS has given 3 phases to reopening. Number 1 criteria on those phases, on phase 1, is that you have to see a 14-day reduction of community spread in your area. We don't have that. We're in the opposite direction. So phase 1 isn't coming anywhere close. And it's not even till phase 2 that you can have limited visitation. Yeah, I mean, I've seen people outside the plexiglass and things like that, but that's not much. And even those places like in the Northeast where they've kind of gotten through the hump, it's basically 2 people sitting on opposite ends of a long picnic table, everyone wearing masks with a chaperone to make sure nobody hugs anyone. So that's kind of where we're at. In addition to that, access to care is limited. A lot of physician offices, specialist offices were shut down for a while, or they've kind of made a transition to telemedicine, with varying success, or they've had to cut down the number of patients they see in the building. Caregivers and visitors cannot come with, maybe one can come. They're having to kind of space out the waiting rooms. It's a lot more difficult. And I will say, I'm just going to stop sharing for 1 second, pause my share to show you this. It's hard to communicate with somebody like this. So if I'm talking to my patients like this, with all this stuff on, they can't really understand what I'm saying. So keep that in mind. That's a lot easier. All right. We'll continue. Thank you. All right. So, hold on. Okay, here we go. So, there's opportunity here, guys. We have to reorient care away from the hospital into ambulatory settings. We have to remember that the hospital should no longer be the hub in the hub and spoke system that we've had for a long time. We've been going in that direction. Hospitals have been encouraging that because why do you think they're getting into the post-acute settings or into the community healthcare settings? Because they know that that's not where the payment models are going for them. But this is a real opportunity for us to start bringing care to the patients. We need to use telemedicine more. It's there. Using telemedicine, you can connect patients and families. I've had multiple situations where I've had, a 3-way conference, one with the patient, one with the family. The family gets to see the doctor and talk to them, see their loved one, talk to them, and we can all communicate a lot better. This is a chance for us to bring healthcare to where the patients are because we're not wanting to take them out of their nursing home or their assisted living or their independent living facility for them to go to the doctor, go somewhere, because every time they leave, they come back, you got to start over that 14-day quarantine. That's a huge problem. So why not bring it to them? Partnerships in the bubble. A lot of you may have heard about COVID bubbles. Some countries have made COVID bubbles where they've been pretty good on COVID, and they've said, okay, we can have travel back and forth. Why can't we do that with various settings and delivery delivery of healthcare services, where we have an assisted living facility, working with a hospice, working with home care, working with home health, and say, okay, we're a bubble. We can work together, right? We're testing together. We are monitoring together. So we can deliver these services, because to silo ourselves so much is really adding insult to injury when it comes to the isolation that our patients are facing. And then we redefine what is essential. We've thought about the care provided in a senior living facility is really, we just kind of do that while the patient's here, and we're not really taking control or even giving control of the care to the patient. It's all run by someone somewhere else in a hospital or an office somewhere. Well, we can take care. We can take control of some of that as well. I don't know if anyone remembers the $6 Million Man back in the day, but we have the technology. We can rebuild it. Telemedicine's a part of it, not everything, but it's a part of it. Virtual health gives us a chance to connect with patients. We should use it as a primary means, not simply as something that we do when we can't get somebody in. It's a chance for us to get families in for meaningful connection, to have meaningful conversations. I've had hospice discussions online very effectively with families, because when you're in a virtual communication setting like this, you've got to look at somebody. They got to look at you. And guess what? They can see my face, whereas they can't see my face when I have all that stuff on that you just saw. We can cut down transportation, not just cost, but also the isolation that comes with it afterwards. We can coordinate with specialists better. And we can redefine what is primary care. Primary care should be the care that we provide to the patient where they live, and should be the care that is driven by what it is they want in life. So we talk about disruption. You've heard about disruptive things a lot. We talk about how Amazon has disrupted book selling or selling online, or other companies like that. Disruption can be a positive change. We have to look at healthcare access and healthcare as an amenity. We have a lot of senior living settings that have really invested in making it very, very nice, but the healthcare hasn't gotten any better, or the healthcare really isn't there. Patients want this. And I saw someone shared a very good article earlier this week that certain senior living companies are aiming for this now. They're looking at this because patients need that. They know, and families need it. They know that their loved one can't go somewhere. So can you bring them healthcare? Healthcare can be delivered. If Grubhub can do it, why not us, right? Reorient payment models. Maybe it's something where people are paying for, facilities are paying for access. They're paying for that kind of amenity. It's something that we can look at. Again, using more is not always using better. We have to think about, how are we doing this well? We have to listen to what our patients want, because this is a great opportunity. We've talked a lot about how in COVID, that's given an opportunity for people to talk about end-of-life care. Why did we wait till they got COVID to discuss that, right? And most importantly, this has got to be an ongoing discussion that we're all paying attention to, that we're all participating in. This is how we are going to make progress. And questions and discussion. So fire away, everybody.